No jokes on the fourth, okay?
I'm sorry, what kind of jokes?
No jokes on the base.
No. This is serious.
Serious stuff.
Serious stuff.
Whose office are you in, Dan?
Arnie Baskin's conference
Oh,
room.
the conference room. Okay.
I couldn't go into your room. Dr. Hess was making too much noise down the hall.
He did a penile implant on Friday. I can't believe it.
Dr. Hess did.
Yeah. He had
Interesting.
nothing to do.
Okay. We have some people filtering in, so I'm going to give it another minute or two.
I'm gonna put myself on mute right now.
Sounds good.
So I'm going to stop my, well, I guess we can just leave my slides up, right?
Yes, no, I don't have slides, so you're gonna. Okay, so I'm going to get started. Good evening, everybody. Thank you for joining us. I'm Therese Gardier. I'm the CME Director for the Department of Urology at Yale. Welcome to our first annual Urology Hot Topics module series. Tonight, we have the pleasure of having Dr. Stan Honig and Dan Kellner speak to us this evening. Dr. Stan Honig, is a professor of clinical urology and director of men's health at Yale School of Medicine. He has been a clinical professor of surgery and urology and obstetrics and gynecology at UConn School of Medicine since 2008. He graduated medical school with an MD with distinction in research from the State University of New York at Stony Brook. He completed his urologic training at Boston University School of Medicine and a fellowship in reproductive medicine and surgery at Baylor College of Medicine in 1993. He is the past president of the Society for the Study of Male Reproduction, a society of the American Urologic Society, and is the current president for the Society of Male Reproduction Urology, again, a sub-society of the American Society of Reproductive Medicine. Currently, he is the chairman of the Sexual and Reproductive Committee of the Urology Care Foundation. He has a large urologic practice that subspecializes in male reproductive and sexual medicine and surgery. His urologic practice specializes in clinical and basic science research that focuses on male reproduction, vasectomy, erectile dysfunction, testicular cancer, fertility links, anabolic steroid use, hypogonadism, and gender-affirming surgery. He is an expert reviewer for the Journal of Urology, Urology, Fertility and Sterility, International Journal of Impedance Research, Journal of Sexual Medicine, Journal of Andrology and Reproduction. And tonight he is going to lecture for us on male infertility, to be followed by Dr. Dan Kellner, who is an assistant clinical professor in urology at Yale. He has been providing urologic care in the greater New Haven area and the Shoreline since 2005, a graduate of UConn School of Medicine. He trained at Lenox Hill in New York City. Dr. Kellner offers his patients laparoscopic, robotic, and other minimally invasive techniques for treating urological disease. A large focus of his practice is men's health issues with a strong interest in helping men manage benign prostatic hyperplasia. Dr. Kellner offers several state-of-the-art treatment options for BPH, including office-based procedures such as UroLift, as well as several surgical treatments for BPH, including TURP, green light laser treatment, and HoLEP. Dr. Kellner is the first and still the only urologist in Connecticut to offer HOLIP to men. So thank you both for joining us tonight. We'll start with Dr. Honig. Thank you. One housekeeping issue for anybody with questions, please use the chat or Q&A. I will be scanning that throughout the evening, and we'll do questions for both Dr. Kellner and Dr. Honig at the end. Thank you.
Thanks, Therese, and welcome everybody. Hope you'll enjoy our hour to share some of the basic concepts of male reproduction and prostate health with our experience at Yale. So I'm going to talk about the new male infertility guidelines and really what the important things that the average physician or practice provider should know about male factor infertility. This is based on guidelines that are listed here that were published in October of 2020 by a group of reproductive urologists. And basically what they did, they asked different questions, and this is all evidence-based guidelines. And based on the evidence, each guideline was assessed a strength rating, either high, moderate, or low support. And based on that, recommendations were made. And if there was not evidence-based data, then the experts then gave their clinical opinion and they made some guidelines. It then went out for peer review to a group of other reproductive urologists and then came back for finalization. And this is the practice guideline that is being utilized today. And for instance, the moderate recommendations, as you can see here, can be based on either A, B, or C guidelines. And you can see the A guidelines are based on evidence-based data that are unlikely to change with future research. And those are usually the randomized controlled trials. The B level data looks at things that might change with more data. And those are the kind of more the observational studies, my experience, your experience, things like that. And then the last group where with more data, maybe things are likely to change. And based on that, you can either get a strong recommendation, a moderate recommendation. Moderate recommendation means that there's probably going to be net benefit as opposed to a conditional recommendation where there may not be benefit or harm. So it is something that's reasonable to offer patients. And lastly, where there are no recommendations and there are no evidence-based data, the comments are made based on expert opinion. So there's actually 52 guidelines, and we're not going to go through all these. We're just going to try to highlight the important ones that I think are important for most doctors to understand. So number three, I think is important. Men with one or more abnormal semen parameters or presumed male infertility should be evaluated by a male reproductive expert with a complete history and physical examination as well as other directed tests. So what's an abnormal semen analysis? Okay, well, these are the WHO guidelines based on 2010, where they looked at over 1,800 new fathers from multiple countries and continents. And what they found was the average sperm count was 73 million sperm. And two standard deviations from that is 15 million sperm. And the 15 million is really what we use as not really a normal cutoff, but just the 95th percentile. And anything less than 15 is considered abnormal. Similarly, with motility, meaning sperm motility, the mean in that group was 61%. Two standard deviations was 40%. And with volume, the average was 3.7 cc's, where the two standard deviations was 1.5 cc's. They also look at the shape of the sperm or morphology. Okay, and you can see in this slide, there are many, many defects that we can see. And here we see what looks like a completely normal looking sperm, which is a head, which has an acrosome, which is 2/3 of the head, a mid portion that looks reasonable in size, and the tail. and that's considered normal, strict morphology. And in all men whose wives are getting pregnant, they only have about 4 to 10% completely normal looking sperms. 2 standard deviations below that is 4%. So anything less than 4% is considered abnormal. So if you look at the characteristics here, you see the volume, the borders of normal are 1.5 cc's, 15 million sperm, progressive motility of 32%, and normal morphological forms as 4%. And that's what we consider abnormal sperm parameters. Now, you can have numbers higher than that and still have problems getting pregnant. You can have numbers less than that and still get your partner pregnant. But these are the numbers that we're using on a regular basis. Now, 5 and 6 are very important as well. And this is relatively new concepts. And it says that clinicians should counsel infertile men with abnormal sperm parameters of the risks, the health risks associated with abnormal sperm production. And that was based on a moderate grade B recommendation. And infertile men with specific identifiable causes of male infertility should be informed of the relevant associated health conditions. So here we go. This is a slide showing the patients who have abnormal semen parameters. And it turns out that those patients have a higher incidence of testicular cancer either before, found at the time of evaluation, or later on in life with a higher incidence of testicular cancer. Interestingly, there's also been a couple of studies that showed if you have a series of abnormal semen parameters, you're more likely to die earlier, and you're more likely to have a higher Charlton comorbidity index. And these have been shown in multiple studies, as opposed to these other conditions on the right, which have shown single study abnormalities, diabetes, multiple sclerosis, epididymitis, and unclear data based on things like prostate cancer, et cetera, where there's been occasional studies that have shown something. So really, this is a new concept that men who appear to be subfertile are at higher risk of certain things down the line that are important. By the same token, men who present with infertility have a higher incidence of other abnormalities, so Klinefelter syndrome, and they have testosterone deficiency, cystic fibrosis. Men who have cystic fibrosis are born without their vas deferens. They have other abnormalities, pulmonary, pancreatic, et cetera. Patients who have undescended testicles or cryptorganism have a higher chance of testicular cancer. And those that present with infertility who have a testosterone deficiency have a higher incidence of diabetes, metabolic syndrome, cardiovascular disease. And all these things are things that we have to counsel our patients who are subfertile about subsequent problems going on in life. Now, number 7 is very important as well. And this is a relatively new concept. Clinicians should advise couples with advanced paternal age, which is greater than equal to 40, that there is an increased risk of adverse health outcomes for their offspring. And that's expert opinion, okay? And we know that maternal age puts offspring at higher adverse effects, but this is the first time that we're identifying this in older men as well. And this is through effects on reproductive hormones, semen parameters, et cetera. So if you look at the effects of male age on reproduction function, you can see on the left here, all these things that can affect semen parameters and subsequently may end up with problems with offspring. So higher abnormality of sexual function, sperm parameters, genetic abnormalities, specific abnormalities of the DNA and epigenetic changes, higher miscarriage rate, higher preterm birth, and again, yes, higher incidence of adverse outcomes in offspring. And there's becoming more and more evidence of this. Now, this is not a new concept. This was actually noted many, many years ago that advanced paternal age may be associated with certain genetic syndromes. And we know that as men age, there are higher changes in DNA changes that can either be post-zygotic, they can be in the germline, they can be prenatal, et cetera, that can portend a higher chance of finding genetic abnormalities in the male of advanced age. And we know that, for instance, paternal age explains a large percent of the variations in the mucosa and the mutation rate in the human population. And this is just a list of some of the genetic conditions that are of higher incidence in offspring that's associated with advanced paternal age. And the relative risk is higher in things like achondroplasia, Albert syndrome, and also conditions in the left corner here, such as schizophrenia and autism. And the incidence is still relatively low, but it is higher once you hit 50, and once you hit 40, it starts to bump up a little bit. Really at 50, that's when it really becomes an issue. So really the first time we're looking at paternal age as being a concern here. Lifestyle issues. 8, clinicians may discuss risk factors such as lifestyle, medication usage, environmental exposure that are associated with male infertility, but patients should be counseled that the current data on the majority of risk factors limited. So we know that smoking is an issue. We know that obesity is an issue, but there are some studies that show pro and con. It's very hard to identify these variables as independent risk factors because there's so many confounding variables going on. Number 9, the results of a semen analysis should be used to guide management of the patient. And the results are greatest concern when there are multiple abnormalities that are present. So if you focus here on the graph to the right, you see that the chances of infertility increase exponentially as the number of abnormalities have increased. So the concept of a combination of low number, low movement, low shape, the more abnormalities you have, the higher chance you are of having problems with infertility. The genetic testing has become important in male factor infertility. So for instance, a karyotype and a Y chromosome microdeletion is recommended for the evaluation of males who present with either very low numbers, less than 5 million, or those who have no sperm in their ejaculation. So for instance, we'll pick up on a karyotype, Klinefelter syndrome, we'll pick up balanced translocations that once the genetic material splits up, you can see problems with unbalanced translocations and birth defects. And you can also find abnormalities with the Y chromosome. And depending upon the location of the abnormality on the Y chromosome, it may portend a situation where either you have a very small amount of sperm in the ejaculate, or no sperm in the ejaculate, but sperm in the testicle, or no sperm in the ejaculate or the testicle. But if a male has this Y chromosome abnormality, that is something that he will pass on to a male child. So there is the opportunity, for instance, in IVF to sex select and put back embryos that are female to save this issue going forward down the line. How about varicocele repair? Well, we know that surgical varicocelectomy should be considered in men attempting to conceive who have palpable, meaning you can feel it on physical exam, varicoceles, infertility, and abnormal semen parameters. And that's based on a large amount of grade B level evidence, and it's a moderate recommendation. But we don't recommend varicocele repairs in men who have non-palpable varicoceles. So patients who don't have one that you can feel on ultrasound, on physical exam, but you only see on ultrasound, those aren't the people that we're fixing varicoceles on because they don't see the improvement in semen quality. Now, if you take patients who have varicoceles, they'll have a baseline pregnancy rate, if you do nothing, of about 17%. But if you fix their varicoceles, they'll probably double their chances of getting pregnant compared to natural intercourse. And this, of course, it differs based on semen quality. So if you have a guy who has a very low number, very low motility, he's not going to have the same result with a varicocele repair as someone who has kind of moderate numbers like 15 million and 25% motility. So we don't recommend varicocelectomy in men who had non-palpable varicoceles, that are those detected only by imaging. And you can see the images here on the right, and physical exam where you can see the varicocele, the clinical varicoceles on the left. Sperm retrieval. Okay, so for men with what's called non-obstructive azospermia, so men who have no sperm because they have a problem with production, they can undergo sperm retrieval. And usually this is done by what's called a microdissection technique. And I'm going to show you some slides of this today. There are different ways to do this. There's a percutaneous approach. And with the microsurgical microdissection, about 50% of time, if you have no sperm in the ejaculate, will actually be able to extract sperm from the testicle and use that sperm with in vitro fertilization to help couples get pregnant. This is a slide showing a needle aspiration, which we don't use in non-obstructive azospermia, but we do use in obstructive azospermia. And this is the open testis sperm extraction. Some of you may not want to look at these pictures, but this is an open testis biopsy. And we take a little sample. And if we don't find sperm on a little biopsy, we do this microdissection where we actually open up the testicle, we bring in an operating microscope, and this is an intraoperative picture where we've actually bivalved the testicle. You can actually see the tubules sitting in the testicle. This is all under the operating microscope. And you can see this slide that I borrowed from Peter Schlegel at Cornell, where some tubules look bigger than others, where you can see sperm in them, where other tubules just show these tubules that show very little sperm in them, and those are called Sertoli cell only tubules. Okay, so we take a piece of tissue out in the operating room, we look at it under the microscope. This is a picture showing a normal tubule with lots of sperm in it, and here's a tubule with only these Sertoli cells. So you can see the difference: full tubules, no tubules, just these Sertoli cells. And here's an interesting slide where most of these tubules have very few cells in it. But look at this. You have one tubule here that has a lot of sperm in there. And those are the tubules that we're able to pluck out and find the sperm that is utilized for intracytoplasmic sperm injection and in vitro fertilization. I'm just going to skip ahead to slides with sperm retrieval in what's called obstructive azospermia. Okay. And this is some slides showing what's called an epididymal aspiration, where we go in and extract sperm directly from an epididymis in cases that are obstructed. So cases like a vasectomy, or cases of a person who was born without their vas deferens, or someone who has a blockage of his epididymis from epididymitis, things like that. You can do it multiple ways because there's tons of sperm in the testicle. You can do it with an aspiration. You can do it with a mini testicular sperm extraction. We do this open procedure where we extract sperm from the epididymis. And regardless of the case, you will have a large amount of sperm coming out with this procedure that can be utilized, but only for in vitro fertilization. So in the benefits of time, I'm going to stop here, and I'm going to pass the baton over to Dr. Kellner to talk about some of the issues, state-of-the-art issues relating to prostate health and BPH. Can you hear me, Dan?
I can hear you. I think you're still sharing your screen. I think you have to push stop share.
Okay, I'm done.
All right, can you see my slides?
We can.
Okay. Well, good evening, everyone. Thank you for having me talk about BPH. We're going to talk about surgical treatment of BPH, how to tailor the treatment to the patient. There are many, many different treatments, surgical treatments for BPH over the past few years, and What I want to talk about today is just trying to figure out which is the best procedure for your patient. I don't have any disclosures. The learning goal is to discuss indications for the surgical treatment of BPH. And then we're going to talk about how you tailor BPH surgery, thinking about patient factors and thinking about prostate factors. And then we're going to do a few case presentations just to give examples of choosing the right treatment, even though there are many treatments that you could choose from. Just briefly, we'll talk about BPH, something that seems to occur more prevalent in men as they age. By age 50% of men have BPH with clinical symptoms. BPH is growth of stromal and glandular cell in the surrounding the transition zone of the prostate that surrounds the urethra, and that can cause obstructive symptoms. So on the picture of the left is a somewhat normal prostate, and the picture on the right shows BPH growth, which is causing obstruction to the urethra and encroaching on the bladder. Now, symptoms related to BPH are categorized as irritative symptoms, and this could be things like frequency of urinating, urgency to urinate, let me go back up, urgency to urinate, getting up at night to urinate, which is nocturia, or even discomfort with urination, such as dysuria, or obstructive symptoms, such as a weak stream, intermittent stream urinary hesitancy, where the stream starts and stops, incomplete voiding, dribbling, or straining to void. Now, when we start to treat BPH, if someone is not that symptomatic, we may just do watchful waiting or do some behavioral modifications by counseling patients to decrease their caffeine intake, alcohol intake, see if they're taking any medications which are diuretics. Maybe they could take those medications in the morning versus taking them right at bedtime. Some patients have strategies such as time voiding, where they urinate before they have an urge to urinate, or double voiding if they urinate a few times to feel that they've emptied their bladder. And if conservative measures don't work, then medical therapy could be used, such as alpha blockers, which work rather quickly. Medications like tamsulosin or lofuzicin usually work within days to relax the prostate and make it easier to urinate. Other medications, such as 5-alpha reductase inhibitors, such as finasteride or dutasteride, work well, but they take about 3 to 6 months before there's any clinical benefit. And unfortunately, both alpha blockers and 5-alpha reductase inhibitors do have side effects, and many of them could be sexual in nature, which could be disturbing to the patients. Phosphodiesterase inhibitors, such as daily tadalafil, Cialis, has shown some benefit in helping urinary symptoms in men who have BPH. And then there's a role for anticholinergics, or the combination of different medications, and some patients will benefit from phytotherapy, such as saw palmetto or other agents. Now, there are certain described indications for surgery according to AUA guidelines. And the picture on the right shows all kinds of problems that have happened because of BPH. We have a very thick-walled bladder with bladder diverticulum that have formed because of the high-pressure urinating, bladder stones which form, and then pressure that goes up to the kidneys causing hydronephrosis. And in summary, refractory urinary retention, recurrent urinary tract infections, recurrent gross hematuria, worsening lower urinary tract symptoms refractory to medical therapy, renal insufficiency, large bladder diverticular, bladder stones are all potential reasons for someone to undergo surgery. Now, the gold standard surgery is often called the TURP. That's where we put a rigid scope through the urethra under general anesthesia and use electrical energy to shave out the inside of the prostate. Now, the issue with this surgery is it needs general anesthesia. It's often done in an inpatient setting, almost always, and patients require continuous bladder irrigation after the procedure. And there are many complications. And what's most disturbing is ejaculatory dysfunction for many patients, but you could also sometimes have trouble with erections, urinary tract infections, bleeding after surgery, incontinence, and TUR syndrome, where you could have low sodium, and that's when we use hypotonic solutions such as sorbitol when we're resecting. So there's been a movement towards minimally invasive surgery for BPH, and the goal is to have the efficacy of a TURP, but with a more favorable safety profile. And a procedure like this would ideally be cost-effective, easy to perform, have a rapid and durable relief of symptoms, be performed in ambulatory setting under local anesthesia with a short recovery time and a smooth return to normal activity, and hopefully preservation of sexual function. Now, in general, as procedures become more invasive, they become more effective. So the least invasive are the medications, and they're least effective. We get into the minimally invasive procedures, which we'll talk about in a moment, And then we can talk about definitive procedures, which are the most invasive but the most effective. And what I mean by definitive is it's a procedure that's going to have a durable outcome, and it's unlikely that you'll ever need another surgery. Now, I want to talk about tailoring Bph treatment. Now, you can think about patient factors. First of all, what's the indication for the patient needing surgery? Are they in retention? Do they have bladder stones? All the things that we mentioned before. There's a test called an Aua Score, which almost all urologists use, and that's a way to measure the degree of bother, the degree of symptoms and the bother related to the symptoms. We also need to look at the patient's risk tolerance. How do they feel about going to the operating room? You know, what are their comorbidities? Do they have lung disease or heart disease? Is it safer for them to have a procedure in the office versus something that's more serious? And are they on anticoagulation? And is it safe for them to stop the anticoagulation, and for how long? Are they sexually active is a very important thing to discuss with the patient, because many of these procedures will affect sexual function. And then think about life issues. Do they have to work? Family responsibilities. And the AUA score we mentioned before, that's a way to measure patient symptoms. And it's 7 questions looking at irritative and obstructive symptoms scored between 0 and 5. And based on your score, you'd be categorized as having mild, moderate, or severe symptoms. And this is a way to kind of assess someone's overall symptoms and then also response to therapy. Now, one thing that's very important is prostate factors. Now, the pictures I show of these bagels illustrates prostates. Now, one of the big misconceptions in BPH is that patients will come to the office and they'll say that they don't have BPH because their primary care doctor told them that they have a normal prostate. Well, these bagels are examples of prostates. The small bagel, which would represent a normal sized prostate, has a lot of dough in the donut hole. And so this particular prostate has prostate tissue growing into the hole, and that's going to be an obstructive picture. Versus the large bagel on the right, which would be a large prostate, happens to have a large hole in the middle. And so this is not an obstructive type of prostate. So there's really no correlation with the size of the prostate and the symptoms. Now, the shape of the prostate is somewhat important, and that's there are different shaped prostates, which we could often assess with imaging or cystoscopy, and certain procedures are good for certain types of prostates, and we could talk about that in a moment. And it's also important to think of concomitant disease. Does the patient have something besides enlarged prostate, such as does he need treatment of bladder stones? Does he have a bladder tumor that needs to be addressed? And also, has he had previous treatment? Has there been previous BPH surgery, or has there been previous radiation, which could affect future surgeries? Now, the AUA has stratified prostates into small, average, and large size prostates, and then given a kind of a list of procedures or surgeries that would be appropriate for that size prostate. Now, it's a busy slide, but one thing I just want to point out is across all sizes is HOLEP and FULEP, and those are enucleation procedures. And those are the only procedures that are considered size independent, where you could treat any size prostate, small, average size, or large. As I mentioned before, the shape of the prostate is important. On the left, we have a cystoscopic view of the prostate, where we're seeing lateral lobes. That's a type of prostate where we could do possibly a urolift, and we'll talk about that in a moment. On the right, there are no lateral lobes. What we have is a big, tall wall right in the back of the prostate. And that's a high median bar, and that person could do better with a different type of procedure and not a urolift. So it is important to be able to identify prostate anatomy to know what the best procedure is as well. So let's talk about a patient. Patient number 1 is a 58-year-old male who has BPH associated lower urinary tract symptoms. He complains of a slow flow and urinary hesitancy. He works as a mail carrier, and he knows the location of all the bathrooms on his route. He's been on tamsulosin for a year, and he has retrograde ejaculation. He also feels the medicine is making him tired. It's very important for him to preserve sexual function. His AUA score is 28, which corresponds that he has severe symptoms, and a quality of life score of 5 means that he is unhappy with his condition. A prostate ultrasound measures the prostate at 45 cc's. It's kind of a small to average size prostate, and there's no middle lobe identified. So for this particular patient, it should be considered that he would have a procedure called a urolift. This is a good example of a minimally invasive procedure that can be performed in the office with a local anesthetic. Basically, it's implants that are put into the prostate. If you look on the bottom right, you'll see that there are metal clips with a monofilament suture, and these clips are placed through the prostate. I'll just play this short video. There's a needle that puts through the prostate. There's a clip on the outside of the prostate. There's a second clip on the inside of the prostate. And there's ratcheting, creating tension between the clips. And it squeezes the prostate, pulling the inside of the prostate towards the outside of the prostate. Typically, 4 to 6 clips are placed in the prostate to open up the channel. And if you look at the bottom, you have a before and after view of the prostate after a UroLift procedure has been performed. There's a study called the LIFT study, which was the study that got UroLift approved. And just to summarize what this table is showing us is there's improvement about 10 points in symptoms, and this is durable over 5 years. The next line shows that the quality of life is improved, durable over 5 years, and Qmax is how strong the urine flow is, which is improved, also durable over 5 years. The actual retreatment rate for UroLift is 13.6% at 5 years. And if on the bottom right of the table, you can see that UroLift has a low retreatment rate compared to other procedures. Now this is a slide that shows ED is erectile dysfunction, EJD is ejaculatory dysfunction, and this shows the percentage of ejaculatory dysfunction and erectile dysfunction with different prostate procedures. UroLift is the only procedure that claims 0 erectile dysfunction and 0 problems with ejaculation. Another procedure that can be considered for this male carrier is a procedure called Resume. This is also a procedure that can be done in the office with a local anesthetic. This is where you have a device that goes into the prostate. There's a needle that's placed into the tissue, and convective radiofrequency energy is placed, which is water vapor. It damages the tissue cells, and with time, there's cell necrosis, and the tissue gets reabsorbed. This is a procedure when it's compared to controlled study. It shows that there's been 11-point improvement in the AUA score, and at least a 50% improvement in quality of life and urine flow. There's about 3 to 4 year follow-up now for this particular procedure. One thing with this procedure is you don't have benefit right away. Patients do have a catheter placed, and the catheter stays in for a period of about, I think about 4 to 6 weeks. Aquablation is another procedure that can be considered for this particular patient. Aquablation is a FDA-approved robotically controlled high-pressure water jet. There's real-time ultrasound that's performed transrectally, and the prostate is mapped out, and the water jet basically goes through the prostate, creating a hydrodissection and ablating tissue. Now, the issue with this particular procedure is there is no hemostasis during this procedure, and so the urologist needs to either put a balloon inside the prostate and put it on traction, or go inside with a cystoscope and fulgurate or burn the areas afterwards. So the problem is bleeding after these procedures. There's a study called the Water Study, which randomized patients, and it compared aquablation to TURP, and they found that aquablation is non-inferior symptom relief compared to TURP. So TURP and aquablation are pretty equal, but aquablation had a better profile in terms of sexual dysfunction, where there was difficulty ejaculating in 10% of patients with aquablation versus 36% of patients with the TURP, and I think the number is usually listed as higher than that. All right, a second patient that we're going to talk about is a patient who has a massive prostate, 72-year-old. What we're looking at here is a picture of an MRI, which shows a very, very large prostate, which is extending up into the bladder. This patient has had infections with epididymitis. He is not sexually active. The prostate measured 240 cc's, and he wants to be catheter-free. Now, traditionally, a prostate this big would have to be tackled with an open approach, with a surgery such as an open prostatectomy. That's where an incision is made in the lower abdomen. The bladder is opened, a glove finger is placed down at the prostate, and the inside of the prostate is enucleated. And this is a morbid procedure with prolonged hospitalization, prolonged time with a catheter, and long convalescence. These days, we can do that same simple prostatectomy without any incisions using what's called the holmium laser enucleation of the prostate, or HOLEP. The prostate is kind of like an orange. There's an outer surgical capsule, which is like the orange peel, and the prostate tissue is like orange pulp. And you can imagine if you take your finger and you put it into the right plane in an orange, you could peel out the inside of the orange. Well, on the bottom of this picture here, you can see that with the cystoscope and using laser energy, we could peel out the inside of the prostate, move all of that tissue into the bladder, and then we use an instrument called the morcellator to remove the tissue. And this is a very, very effective procedure that you could do prostates all sizes and configurations. And we use normal saline, which is safe for the patients. There was a meta-analysis by Dr. Fung from Arizona, who basically looked through papers comparing HoLEP to open prostatectomy and to TURP. And compared to TURP and open prostatectomy, the HoLEP had greater improvement in urinary flow, greater improvement in symptom score. There was a lower rate of recurrent symptoms at 5 and 10 years. The chance of another surgery after HoLEP is less than 1% versus TURP is 7.4%. There are short catheterization times, decreased length of hospital stay, and very few serious postoperative complications. And it's possible to treat very large prostates, comparable to an open prostatectomy, but with radically decreased morbidity. I'm just going to show a few seconds of a video of HoLEP, just so you can see what it looks like. But this is the inside of a prostate, 65-year-old man who has a bladder stone. So you can see this obstructive tissue we have to push through to get to the bladder. There's a stone which is free floating on the bottom of the bladder. The green that's going to show up on the bottom is a laser, Honig laser. We use the laser energy to actually fragment the stone and remove those pieces. And here we're using laser energy to make an incision into the prostate. First, we cut the mucosa of the prostate, was the inner lining, and we get out to that outer lining where we can kind of peel things away. And this is going to go rather quickly. You can see that we find a plane. You can see the tissue kind of peels up as we're working, and we're working in a pretty much bloodless plane. This particular HoLEP is being done in a segmental fashion where there's several pieces being divided and done independently. Often we do these surgeries en bloc where we do the entire prostate as one big piece, which is more efficient. And that's how I'm doing the procedures now. So here we are, we release the prostate tissue into the bladder. Here's another piece of tissue that we're removing now. This is coming from the side of the prostate, so lateral lobe. To your left is the prostate tissue that's being released. To your right is the capsule of the prostate. And again, we're going to deliver this piece of tissue into the bladder. And then in the end, we have this big wide open channel. There's no obstructing tissue. It's almost a bloodless plane. If there is any bleeding, we can control it with the laser. And to finish the procedure, we place the morcellator, which is going to appear. And here's our morcellator. It goes through the penis, and the tissue is fragmented into tiny pieces and sucked out of the bladder. And so there is no incisions to remove a very, very large amount of tissue. At Yale, we're the first hospital to offer HoLEP and the only hospital to offer HoLEP. We're very proud of our team. We came up with a contest and to name our team, and we are the HoLEP Healers. And our slogan is "Peeling is Healing" since 2019. And to get a shirt, you have to come to the OR and actually do something. You can't just see me in the hallway. In summary, when we're tailoring BPH surgery, there are many available surgical treatments for BPH. Urologists should be familiar with several options. It is important to consider patient and prostate factors when choosing the best option. You have to think about the patient's symptoms, their anatomy, think about the efficacy and durability of the procedure, comorbidities of the patient, and side effects of the treatments. And together, the patient and the urologist can decide on the right treatment. And that's the conclusion. So.
Thank you very much. I don't see any questions here. If anybody has them, please enter in the chat. We'll hold on for a couple of minutes.
I actually have a question for Stan. So Stan, when you're doing that microscopic work and you're identifying those tubules and you see the sperm, is that the actual sperm that you're trying to retrieve? In other words, is that diagnostic and therapeutic at the same time?
So I think what you're asking me is, when I'm looking at the tissue, am I actively looking at sperm? Is that what you're asking me, or?
Yeah. So I mean, when you're taking those samples that you're showing, the cross sections of the tubules,
right?
The different ones, and you've identified some that are just Sertoli only, and some that are loaded with sperm, like there are little islands that had sperm.
Right.
Is it right there and then that you're actually harvesting the actual sperm?
Right. So actually, it's interesting that you mentioned that. Thank you for being my yes man, by the way. Because one of the other guidelines actually says there's no role to do just a standard diagnostic testicular biopsy just to show, okay, the histology is either normal sperm production or only Sertoli cells or what's called maturation arrest. There's no role in 2021 to do just that. So whenever we go in to do one of these procedures, it's always to get sperm. So it's a sperm retrieval. So I'll do the procedure, I'll look at it under the microscope, and if I find sperm, I'll send it over. But if not, then I'll just pluck out some of those tubules that look quote unquote bigger than others. They're kind of plumper. And then many times I'll send it over to the reproductive endocrinology lab, and they may look at it for 4 hours and find 5 sperm. And then they freeze it and they use that sperm for in vitro fertilization. So to answer your question, no, there's no role to just do like a diagnostic biopsy anymore. That's actually in one of the that is one of the other guidelines. And number 2, yeah, we're doing it, and most of the time we're actually doing it ahead of time and freezing the sperm, especially in the obstructive cases where there's usually a lot of sperm available.
There is a question for Dr. Kellner. What are the risks for patients who decide to delay treatment of BPH for too long?
I mean, that question is a little bit difficult to answer. I think it depends on how severe the BPH is and what are the complications of BPH. So if you have mild symptoms and you don't have any of the surgical risk factors that I mentioned and your quality of life is not affected, then you don't really need to do anything. If you have some of the surgical indications, such as hydronephrosis, you're getting infections, you're having bleeding, you're putting yourself at risk. So that's the one thing I try to explain to patients is when we treat BPH, we're not just treating a quality of life issue. Patients are aware that they urinate very often with urgency, frequency, they're aware of the inconvenience. But when they come to the office and you scan their bladder and they have 500 milliliters in the bladder, they're not aware that their bladder has somewhat deteriorated. And so when they understand that they actually have a more serious issue, then they kind of take it a little more seriously that they need to have some sort of treatment. Also, there is a belief, and it's not always true, but if you delay treatment and say your bladder is very, very, very distended for chronic, very chronic, long period of time, your outcome may not be as good. I think, in other words, you're going to have better recovery of function if you do something earlier versus waiting until the bladder is really deteriorated. So I think I see another question.
Yes, Dan, this is from Richard Dean.
Yeah.
Is there a maximum size of prostate for the Honig procedure, i.e. 400 to 500 gram prostate?
Yeah, so there is no maximum size. I think what it comes down to is your personal comfort. I've done prostates where I've resected 308 grams of tissue. I filled up 6 specimen cups. And I was very, very, I was excited to be able to do that, but it took a lot of work and a lot of effort. So I wouldn't want to make that part of my regular practice. There are some patients or some doctors who will do a 500 gram prostate, but because the morcellation process could take so long, sometimes they'll simply just make a cystotomy and just take the tissue out just like a, through an open approach, or else it could be, several hours after you've enucleated just to do the removal of the tissue. So you could do any size prostate.
Okay, Dr. Kellner, do you have, oh, I lost it.
You have to do a transrectal ultrasound
thank
prior
you.
to the HOLIFT or HOLEP or Urolift.
Yeah. So so for the Urolift, I think it's more important to have a prostate size than the HOLEP. Urolift prostates are usually between 30 to 80 cc's is the appropriate size. The FDA has now allowed prostates up to 100 cc's. Even for insurance reasons, they almost want documentation that an ultrasound has been done, but they don't really specify if it's transrectal or transabdominal. Transrectal ultrasound is more accurate in terms of getting a measurement than transabdominal. In terms of HOLEP, it is really nice to know the size of the prostate, but that's more for planning on how long you're going to be in the operating room, because again, it's a size independent procedure. So, you know, it doesn't matter if the prostate's 30 grams or 500 grams. But again, it's nice to just be able to plan what your experience is going to be.
What is the time difference between a 30 gram or 300 gram?
Yes, I mean, a 30-gram prostate you could do probably easily under an hour in enucleation and the morcellation. I think a 300-gram prostate, it'll take about 2.5 hours to enucleate it, another 1.5 hours to morcellate it. So it's a lot more work. And the other thing I should mention is we're sending 90% of our patients home with a catheter the same day of surgery, and regardless of prostate size. So even, today I had a prostate, I removed about 200 grams of tissue. That patient went home today.
And they keep the catheter for how long?
If patients stay in the hospital, I usually take out the catheter the next day. But if they go home, we usually have them come to the office 2 days later.
Okay. Are patients with transition zone prostate cancer candidates for the HOLEP procedure?
So I've done patients on active surveillance who have grade group 1 prostate cancer, and knowing that they have grade group 1 prostate cancer, and I've found sometimes that I don't find any cancer in the tissue. Other times I find that I have a similar amount of tissue and and still grade group 1. And then on the flip side, a lot of times you don't even know the patient has cancer. So you do the HOLEP procedure and the patient didn't have an elevated PSA and there was no reason to suspect cancer, and you incidentally find it. And that's similar to all the urologists who do TURPs. I mean, there's going to be cancer sometimes, you just didn't know it.
Okay. I think that is it. I want to thank you both again for joining us tonight. Oh, sorry, no, Dr. Honig. Does testicular size correlate with infertility risk?
I guess the general answer to that is yes and no, meaning that if you have someone who comes in who has smallish testicles, typically those are patients that have problems with sperm production. Having said that, there's certainly many patients who come in who have normal sized testicles that just don't function real well. So, and the correlate to that is in the patient that comes in who has no sperm in his ejaculate and has a problem with production. Typically, that patient is thought to have like small testicles and a high FSH and things like that. But the likelihood of finding sperm at the time of sperm retrieval is unaffected by testicular size or FSH. You could have a very high FSH or very small testicles, and you can still find sperm in those testicles when you do a sperm retrieval. So it matters to some degree in general, but it doesn't always correlate with everything.
Thank you. Okay, so that puts us on the hour. Thank you very much both for speaking. Excellent talks. And these will be able to be viewed on our Urology website when the series is over. So thank you very much and have a good evening.
Thank you. Thanks for having us.
Thank you.
Thanks for those who attended. Thank you.